So much. It's so great to be here, and it's great to see so many familiar names in the chat. It's exciting to have people joining from all over the place. I'm going to dive right in. I'm going to talk to you about my local health department study from the peak COVID era. I guess you could argue that we're still in the COVID era, right? It's kind of relentless. Um, and Before I get started, I just want to acknowledge that the main study that I'm going to talk about here was supported with funds from NIOSH during the COVID period. And I want to acknowledge one of my collaborators, Michael Grant, who is a industrial hygienist in the Division of Field Studies and Engineering at NIOSH. He contributed to the conceptualization of the study and publications related to the study. Okay, so while my presentation will largely focus on local health departments' responses to COVID-19 in workplaces in their jurisdictions, I'm going to start by providing some historical context about state and local health, local public health authority, and some key historical precedents that really help us to contextualize health departments' actions during the COVID-19 pandemic. Then I'll walk you through the actual study, the COVID-19 local health departments and workplaces study, which included a nationally representative survey of local health departments in the US, followed by some in-depth interviews with several health department leaders across the country. Though I'm not going to talk at length about those. I'm really going to focus on the survey data today. Um, and then I'll end with a brief discussion of COVID-19 era litigation regarding public health efforts to prevent the spread of COVID-19, particularly in workplaces, and kind of the implications of the study findings and what happened litigation-wise in that period. So, like I mentioned, I'm going to start with some historical context. And I will note that this is a very brief overview. You can take whole public health law classes where you learn many of these things, but I'm going to highlight some things that are what I think are most important to kind of situate us in the objectives and the findings for this study. Um, so the United States Constitution grants the federal government limited enumerated powers, which are listed in Article 1, Section 8 of the Constitution. This might be, recap from Constitution studying that many of you may have done. And all other powers are reserved to the states per the 10th Amendment. And because public health authority is not listed among the federal powers, it's understood to be what is referred to as a police power of the states. And courts interpret this to be the authority to protect public health, safety, morals, and general welfare. And collectively, this has established the core constitutional basis for state and local public health authority. And let me say a little bit more about the courts, as given the lack of explicit mention of public health powers in the Constitution, courts have really played a crucial role in establishing public health authority in the US. So public health police powers have largely been defined by, or in the US by challenges that plaintiffs have brought to the courts, challenges of public health measures or regulations, things that have been put into place. And there are several particularly notable examples of court cases that both defined and affirmed the police powers of the states, which you may already be familiar with as studiers of public health, or probably people who paid a lot of attention during the COVID pandemic. And I'm going to highlight two, which were often raised as legal precedents in the COVID era. The first is the Compagnie Française versus the Louisiana Board of Health from 1902, which upheld state quarantine measures even if they interfered with interstate or foreign commerce. And the second is the Jacobson versus Massachusetts case from 1905, which upheld compulsory vaccination under state police power. So just a little bit more background about each of these cases because they have some bearing on what we saw in the COVID era. The Compagnie case took place during a yellow fever outbreak, and Louisiana barred a French steamship from landing passengers in New Orleans under a state quarantine law, even though the passengers were all healthy. And the issue brought to the courts was whether Louisiana's quarantine law violated the Commerce Clause or the 14th Amendment. Um, and the Commerce Clause dictates that states can't interfere with interstate commerce. Um, and in this case, the Supreme Court upheld the law, ruling that states may exercise their police powers to protect public health through quarantine measures, even if those measures affect interstate or foreign commerce. In the Massachusetts case, Massachusetts required smallpox vaccination during an outbreak, and a man named Henning Jacobson refused vaccination, and he was fined. And the issue brought to the courts was whether mandatory vaccination violated individual liberty under the 14th Amendment. And the Supreme Court, in this case, upheld the vaccination law, ruling that individual liberty is not absolute and may be reasonably restricted under a state's police power to protect public health and safety. So these were really foundational, instrumental court cases that shaped a lot of, infectious disease, public health measures for the century that followed, century plus. So in both cases I presented on the last slide, the state was party to the case as authority establishing or creating public health rules fell at the state level. So given that the federal government does not have public health authority, state governments, are by default tasked with public health activities. State legislators create public health codes, and then they delegate the authority to state and local agencies, which then implement and enforce those codes. And though it seems like people are from all over who have joined this talk, I give you the example of California, since this is the UCLA ERC hosting us today, where the state legislature creates preliminary health and safety codes, and the California Department of Public Health implements and enforces, and often informs, in kind of a cyclical manner, what those codes are. Local public health departments generally act under state statutes, though some jurisdictions have independent home rule, and states can delegate to local municipalities the autonomy to manage their own affairs. And that's what home rule is by definition. Or in some cases, a municipality with a certain population will be automatically granted home rule within the state. So Los Angeles County, for example, has its own public health regulations in addition to those that the state of California has. And these include things that are really particular to Los Angeles County's operations. So things like their restaurant grading system, specific disease and control measures, housing and sanitation measures, things like that are all stricter or more specific than at the state level. And importantly, a jurisdiction at a more local level can only have measures that are at least as strict as those at the state level. So this structure, whereby state legislatures pass public health codes and local municipalities might pass even stricter ones, is why most infectious disease interventions are carried out at the state or local level. That's where the rules are articulated and enforcement powers lie. This power largely does not fall at the federal government, though I'll talk a little bit more about OSHA in some coming slides, just to contextualize how that fits in here. Public health departments employ a variety of tools to prevent and mitigate infectious disease transmission within their jurisdictions. and reference to the department's authority to inspect facilities and impose restrictions are consistently noted across state and local public health codes. These are super prevalent. Almost all states have, very similar public health codes, at least in these core areas. And you can see some examples of tools typically utilized by local health departments on the right of the slide. And these include isolation and quarantine measures, which were upheld in the Louisiana case, the vaccination requirements, which were upheld in the Massachusetts case, and a variety of other measures that have been tried and tested, including disease reporting and surveillance, inspection and closure of unsafe establishments like food serving establishments, for example, things like that. I will say here that although states have broad police powers to protect public health, those powers are still limited to some degree by the US Constitution. The most important constraint is the 14th Amendment, which applies constitutional protections against state and local governments. The 14th Amendment requires due process before the government deprives someone of liberty or property, such as in quarantine or work exclusion, and equal protection, meaning that public health measures cannot be applied in discriminatory or unequal manners. And courts generally defer to public health authorities, at least, well, historically, and even now, generally. But they still require that measures be reasonable, evidence-based, and not arbitrary or oppressive. And during the COVID-19 pandemic, courts relied really heavily on the 14th Amendment and the First Amendment to evaluate the legality of restrictions, especially where religious activity or economic rights were implicated. And I'm going to loop back to this at the tail end of the presentation where we talk about some of the specific litigation that took place in recent years. So before I dive into the local health departments and workplaces study, I want to give you a little bit more background specifically about public health intervention in workplaces prior to the COVID-19 era. So again, this is an even briefer overview. There are a lot of workplace kind of interventions that were part of, our history of public health in this country. So I'm going to start with a very simplified timeline where I'll highlight some key developments that led us up to 2020. So public health departments in the US really began actively engaging with workplaces on infectious disease prevention in the late 19th and early 20th centuries. And this timing was shaped by the broad scientific acceptance of germ theory, the rapid industrialization that created crowded factories and sweatshops, and the dramatic increase in new immigrant arrivals seeking to work in urban centers. And the first systematic public health oversight of work environments for communicable disease control in the US really began in the 1880s, not 1980s, 1880s, long time ago. The early 20th century brought expansion of municipal and state health departments and the creation of industrial hygiene programs and greater coordination between labor reform and public health, specifically around infectious disease prevention. And during the 1918 influenza pandemic, public health departments instituted many emergency orders like workplace closures, staggered shifts, mask mandates in factories, and isolation of sick workers to slow down, prevent the spread of influenza. In the 1930s and 40s, we saw federal involvement in workplace health expand really for the first time with the New Deal legislation, with disease control in war production factories becoming a national priority and federal state collaboration increasing, specifically in tuberculosis screening and other vaccination programs. And broader federal level engagement with infectious diseases in workplaces was generally really limited until the passage of the OSHA bloodborne pathogen standard in 1991. Though, theoretically, the formalization of federal level workplace safety standards paved the way for federal enforcement of these sorts of issues via the general duty clause, though that was really limited. There aren't a lot of examples of that in practice. Um, and then in the latter half of the 20th century, state and local health departments expanded workplace engagement through targeted screenings. So, for example, tuberculosis screening in healthcare, and infectious disease outbreak investigation and control, especially with respect to foodborne illness outbreaks. Uh, and then, of course, I'm sure we all remember well, we have the COVID-19 pandemic response activities in the 21st century. And this is really where I'm focusing today. Um, so I mentioned, a little bit about OSHA, and there is some important uh, some important things to consider about the division of authority between OSHA and public health departments when it comes to workplace oversight. So before 1970, workplace disease control was handled primarily by state and local public health departments under their police powers. But with the creation of the Occupational Safety and Health Administration, infectious disease became framed as a workplace hazard, meaning employers had enforceable duties to protect workers. Um, and the clearest pre-COVID example of this that's really clearly articulated with respect to infectious disease is the 1991 bloodborne pathogen standard, which was adopted in response to HIV and hepatitis risks in workplaces, particularly in healthcare. However, public health departments retained many core powers, including quarantine and isolation authority, disease reporting requirements, outbreak investigations, and worker exclusions in sensitive settings like food service. Um, so this division created recurring legal tensions long before COVID. Questions about federal preemption when OSHA regulates workplace hazards makes it not always clear when and if local health departments can engage. And we certainly saw this play out, and I'll talk more about that later. Okay, so this brings me to the main part of my presentation, which is the COVID-19 local health departments and workplaces study. And I wanted to understand how local health departments were engaging with workplaces during the pandemic. So at the conceptualization of this study, we were still in what I might refer to as peak pandemic times. This was about mid-2021. So workplace-based outbreaks of COVID-19 presented a novel challenge, both for employers and public health departments in the US and everywhere, given how rare they'd become in the US over the past century. Local health departments had to respond to these outbreaks while simultaneously providing all of the services that they had been providing, which included far more than infectious disease prevention and control. So here I've included the 10 essential public health services diagram, primarily to remind us all of the many, many very involved and resource intensive responsibilities that health departments already take on, notably in resource constrained environments, even pre-COVID. So personnel at most workplaces also had little experience controlling airborne infectious disease exposures. And health department personnel had limited prior interactions with non-healthcare or non-congregate workplaces to prevent and mitigate such exposures. So, many folks on this call probably work in more traditional kind of, manufacturing production sorts of sites if they're industrial hygienists. And These sorts of infectious disease airborne exposures are not, the top of the list in normal times in terms of hazards to control. So this was a really big pivot for everyone. Um, and so the COVID-19 pandemic served as an opportunity to really understand local health department actions in response to widespread viral transmission in workplace settings, as well as to identify potential gaps in local health department readiness and capacity to engage in workplace-based mitigation or prevention efforts. So this particular study sought to document local health department actions related to the prevention or mitigation of COVID-19 cases and exposures in workplaces, and to also examine facilitators for and barriers to COVID-19 workplace outbreak investigation and mitigation efforts completed by health departments. So I conducted a web-based cross-sectional national probability survey of United States local health departments from January to March 2022. Feels like forever ago and also not long ago at all. The survey questionnaire included 44 items across the following domains. So COVID-19 related complaints in workplaces. So these were things like if they'd received complaints, what types of complaints, things like lack of social distancing, policies, cleaning procedures, masking enforcement, etc. Surveillance of occupational exposures and known positive cases by industry and occupation. So whether the health department collected information about occupation and industry at testing sites, in contact tracing, and so forth. Workplace-based investigations of cases and outbreaks. So whether they did them, if they were in person or virtual, what sorts of interventions health departments put into place, if any, whether health departments worked with other enforcement agencies like OSHA, etc. Questions about local health departments, relationships and interactions with employers or business establishments. So whether they had pre-existing relationships with such entities, if those were positive relationships, things like that. And then finally, local health department capacity and organizational characteristics. So like number of employees, whether there were employees with specific training and exposure assessment and control at the health department, whether health departments had additional resources to leverage, financial, personnel resources, etc. And the survey underwent content-focused review and pre-testing with some subject matter experts from NIOSH and also from the Occupational Health Subcommittee of the Council of State and Territorial Epidemiologists, many of whom actually work at these health departments. So I employed a stratified sampling design to draw a random sample of local health departments from NACCHO's Directory of Local Health Departments. And NACCHO is the National Association for City and County Health Organizations. I am almost positive is what the acronym stands for, but it's an association of health departments. And strata were defined by U.S. Census geographical region and population size served based on the 2019 U.S. Census estimates. And the goal was to have representation from health departments from states across the U.S., including states with a variety of public health governance structures, which I'll talk about in just a second, and also from states with a variety of legislative environments that were friendly or unfriendly to public health generally, especially in the COVID era. So I sampled at the district or regional level in states with public health decision making directed partially or completely by state level decision makers. So for those who aren't familiar, this is pretty complicated. I really had to learn a lot about this in conceptualizing this study. In states with centralized public health systems, the state retains authority over most fiscal decisions, and the local health units, like local health departments, are led by employees of the state. And in this figure here, these are indicated by this kind of medium color blue. And I'm sorry that the colors are so similar. That's just what this figure looks like. I did not generate it. States with shared systems have local health units that may be led by state employees or by local government employees. But regardless, the local government typically has at least a little bit more authority to make fiscal decisions and issue public health orders, though not always. And these are the darkest blue states, and the yellow and purple states fit into this kind of category in this diagram. But decentralized states are all of the light gray states on this picture. And they have local health units with the most independence in hiring, in fiscal decision making, and issuing public health orders within their jurisdictions. So my stratifications included these considerations to make sure that I, had representative samples of each. Okay, so who responded to this survey? 180 health departments responded to the survey, which was about a 15% response rate from the stratified random sample of about 1,200 health departments. And to produce nationally representative estimates, I generated sampling weights for each stratum, accounting for oversampling and differential response rates by strata. And a larger share of respondents represented non-metropolitan areas and decentralized governance structures, as you see here. So for the presentation, I'm really going to focus on findings related to these three questions. What capacities and activities did local health departments report related to the prevention or mitigation of COVID-19 cases and exposures in workplace settings? That's the first question. Which local health department characteristics were associated with those capacity metrics? And which capacity metrics were associated with four classes of activities, these four little bullet points on the bottom. And I'll talk about why I selected those activities when I present the findings related to this question, so you don't have to keep it all in your brain until then. So I'll start by presenting some data regarding this first question about the capacities and activities that health departments reported in the aggregate. So on this slide, I'm going to walk you through some findings related to key capacity metrics of local health departments on the survey. I'm going to present a bunch of tables in the next few slides, but I will point you to the things that I think are most important for you to take away. So approximately half of health departments surveyed reported that they had the capacity to receive, investigate, and respond to workplace safety complaints. This means, though, that about half reported that they did not have capacity to receive, investigate, and respond to workplace safety complaints. And fewer than half reported that they have the financial resources necessary or had the financial resources necessary to adequately support workplace investigation and mitigation activities. When we look at personnel capacity within health departments, only 40% of health departments reported personnel on staff with formal occupational health and safety training and expertise. So this is training. In the survey, this was defined as training and exposure assessment, industrial hygiene, occupational safety, occupational medicine, or occupational nursing. And the majority of health departments reported reassigning personnel or hiring new personnel to assist with workplace investigation and mitigation activities, signaling that they didn't have these sorts of groups already in their health department structure. And respondents almost universally reported positive relationships with local authorities, like the sheriff's department, and more than half reported routine engagement with employers or business establishments pre-pandemic. So I have a really big table of activities that local health departments reported, and I've broken it across a couple of slides. So this first chunk highlights some findings related to health departments' surveillance activities and COVID-19 case-related investigations. So approximately half of all local health departments reported consistent collection of occupation or industry information from individuals through health department administered contact tracing programs. Um, so with contact tracing, health departments work to identify, notify, and monitor individuals who've been exposed to a particular infectious agent. So in this case, SARS-CoV-2, the virus that causes COVID-19. And contact tracing is super involved. It requires a lot of organization and logistics and resources from health departments. Fewer health departments reported collection of this information at testing sites that they administer. And fewer than half of all jurisdictions required employers to report known positive cases to the health department. And I'm going to talk about the implications of all of these things kind of at the end of this little section. But in terms of investigations, over 90% of health departments reported investigating COVID-19 cases linked to workplaces. However, fewer than half of those health departments reported that these investigations were conducted in person at least some of the time. Sorry, I had an extra click there. I'll just point out a couple of notable pieces of information from the data on complaints received from workers, because I know this is a super dense list. But complaints reported most frequently related to enforcement of things like masking and social distancing. And notably, the fewest reported complaints were about appropriate engineering controls, such as ventilation, or complaints about training specifically focused on COVID-19 prevention in the workplace. In terms of actions to address worker complaints, the majority of local health departments reported direct remote engagement with employers or establishments to resolve complaints in lieu of in-person investigations. And then fewer than half of local health departments reported enlisting supports from outside agencies, such as enforcement agencies or non-enforcement public health agencies like NIOSH, to help resolve complaints. And then nearly all local health departments reported receiving requests for support from employers directly, with most requests focused on specific guidance and recommendations for minimizing the spread of COVID in workplaces. Um, and in addition to requests for written information and signage, health departments reported receiving requests to support on-site vaccination efforts, to help connect workers with vaccinations off-site, and to support contact tracing and testing efforts. I just want to note here that many of these activities, especially the vaccination related activities, were like really on the upswing when we did this survey. So it's likely that health departments engaged in much more of this, like in the immediate months following the survey, as vaccination was continued to be rolled out everywhere. Okay. Um, so though there were many, I want to discuss a few main takeaways from the aggregate capacity and activity data, so across all health departments. So health departments did demonstrate adaptability by scaling personnel through reassignment and hiring, but foundational capacity gaps really remain, especially in formal occupational health and safety expertise and funding. A key limitation is the inconsistent collection of occupation and industry data, which restricts the ability to identify high-risk worker populations. If health departments aren't collecting this data, they can't even really start with identifying those high-risk populations. But despite this, nearly all health departments were actively engaged in investigating workplace-related COVID cases. And the shift towards remote or hybrid investigations probably reflects both efficiency, being able to hit a bunch of places really quickly instead of having to travel, But this also probably reflects pandemic constraints, and may have resulted in limited, like, on-site assessment capacity. Um, and then complaints were commonly centered on basic prevention measures. So things like masking, distancing, and cleaning, indicating persistent compliance and enforcement challenges in workplaces. Um, Lower reporting of engineering controls and training issues may suggest under recognition or under reporting of more systematic survey or safety gaps. And notably, like, many workplaces don't have robust ventilation systems. So, this is a fundamental challenge. Um, like with investigations, health departments primarily relied on remote outreach to resolve complaints, which is scalable but maybe less effective for complex or high-risk situations. And collaboration with state health departments was moderate in the reporting, but engagement with federal agencies and worker advocacy groups was really minimal, highlighting potential missed opportunities for broader support and coordination, and maybe highlighting the absence of those relationships being well formed, in general, the siloing that is public health. Um, and employers frequently sought help, especially for guidance and best practices, underscoring the health department's critical advisory role during the pandemic. Employers are reaching out to their local health departments. However, more resource-intensive supports like testing and contact tracing were less commonly provided as assistance, likely reflecting the capacity constraints. Okay, Um, so I presented some aggregate information about local health department capacity for that first bullet here. But now let's look at which local health department characteristics were associated with the capacity metrics. So not the activities, but just the capacity that health departments reported. Um, So I'm going to walk you through these tables. I know it's like a lot to share on a slide, but it is sort of the best way to give you the full picture. And I know you'll get a copy of these slides after the presentation so you can pore over them more. But there were several really notable differences in reported health department capacity by jurisdictional characteristic. So the health departments serving metropolitan jurisdictions and those serving over 500,000 residents, so these bigger ones here, were significantly more likely to report employing personnel with occupational health and safety training and expertise compared to their smaller serving counterparts. The local health departments serving more populous jurisdictions, these really big ones, were more likely to have a dedicated task force for workplace investigation and mitigation activities to report the capacity to receive, investigate, and respond to safety complaints in workplaces, and also to report having sufficient financial resources to support workplace investigation and mitigation activities. And decentralized health departments, so again, these are the ones that retain the most authority over decision-making, fiscal responsibility, issuing orders, things like that. These ones were more likely to report having the capacity to handle complaints than those with centralized, shared, or mixed governance structures. But they were also less likely to report having dedicated task forces to investigate workplaces. So there was some ad hoc investigating likely happening at many. So unsurprisingly, when we stratified by health department characteristics, we found that capacity to prevent and mitigate SARS-CoV-2 exposures was uneven. Health departments serving larger and metropolitan populations were more likely to have the staff with the expertise, dedicated task forces, and sufficient funding, really indicating stronger overall capacity to respond to workplace safety needs in this context. They were able to pivot and do this. In contrast, smaller health departments were less likely to have specialized personnel or dedicated resources, which likely limited their ability to effectively investigate and respond to workplace-related issues. We also see differences by governance. So decentralized health departments reported greater capacity to handle complaints. They were more agile in this realm, but were less likely to have dedicated task forces, highlighting the trade-off between the flexibility and the resource concentration across governance models, or likely highlighting those, not explicit in just the survey data alone. But I did hear this in the interviews. Okay, so finally, let's look at this third question, um, which is which capacity metrics were associated with these four activities: collection of industry or occupation information at testing or contact tracing, receiving requests to evaluate engineering controls like ventilation systems, conducting in-person investigations of workplaces in response to worker complaints, and enlisting the support of enforcement authorities like state or federal OSHA. Um, and the reason I chose these four types of activities was based on their likelihood to be most impactful in actually reducing risk of exposure to SARS-CoV-2 in the workplace. So I'll use the hierarchy of controls to really frame these measures. I know this is like targeted to my super occupational audience here. Um, but if local health departments collected industry and occupation at testing and contact tracing, they could ideally ensure that those workers didn't go to work, really aiming to eliminate the viral sources in the workplace as much as possible. Local health departments that received requests to evaluate engineering controls might be positioned to help make sure employers were better able to reduce viral particles in the air via ventilation, for example, which is also very helpful in eliminating some of that risk. Health departments that were able to conduct in-person investigation after complaints might be better poised to evaluate engineering controls or controls in general, or to advise employers to institute protocols and things to reduce exposure and prevent illness. Like actually seeing the workplace, we know, is huge in informing what sorts of controls we might put into place. Um, Similarly, those that enlisted enforcement agency support, like OSHA, might be more likely to ensure that workplaces received really good guidance. Or if they were flagrantly defying orders, might have some reinforcement to enforce those orders, like OSHA with the general duty clause. Okay, so let's look at what the data tells us. So local health departments with personnel with formal occupational health and safety training, which again, from the second chunk, we know were disproportionately larger populations serving health departments. These were significantly more likely to collect industry and occupation data, to receive requests related to engineering controls, and to actually conduct in-person investigations. For dedicated workforces or task forces, excuse me, we also see positive associations with surveillance and requests to evaluate engineering controls, but not with conducting in-person investigation or engaging enforcement agencies, suggesting maybe that these task forces may better support coordination more than the direct response activities. But we don't know for sure. Increased staffing due to reassignment of personnel or hiring of new personnel appears to generally have helped support more intensive or responsive activities during the pandemic. So maybe with the exception of requests to evaluate engineering controls, though again, the proportion of health departments reporting both hiring new personnel and receiving such requests was pretty small when we stratify. Okay. Sorry, I had a lot of clicks that did nothing. Um, so health departments that reported routine engagement with employers prior to the pandemic were more likely to collect industry and occupation data and to receive requests related to engineering controls. And this suggests that existing employer relationships supported both the surveillance and communication response during the pandemic. Health departments who are engaged with workers may really understand the importance of collecting occupational information and industry in surveillance. We see even stronger effects for positive relationships with local authorities, such as police or sheriff's department. These health departments were significantly more likely to receive requests to evaluate engineering controls and to conduct in-person investigations, highlighting the importance of this cross-sector kind of partnership for more intensive response activities. And then looking at overall capacity, health departments that reported having the ability to receive, investigate, and respond to complaints were more likely to collect surveillance data and conduct in-person investigations. And this reinforces that foundational response capacity translates to more active engagement, unsurprisingly. And similarly, sufficient financial resources were strongly associated with surveillance and requests related to engineering controls. However, financial capacity was not associated with conducting in-person investigations or engaging enforcement agencies, which suggests that funding alone may not drive all types of response activities. Okay, so some key takeaways with respect to capacity and those impactful activities. So first, workforce expertise, particularly occupational health and safety training, appeared to drive action, especially for surveillance and in-person investigations. And this underscores the importance of having specialized knowledge embedded within health departments. These things are fundamental to occupational health and safety training, so it makes sense that we saw these things in those instances when health departments had like an industrial hygienist on staff, for example. Second, increases in staffing, whether through reassignment or new hires, enhanced response intensity, enabling health departments to carry out more resource-intensive activities during the pandemic. And third, relationships matter. So those existing connections with employers, strong partnerships with local authorities appear to facilitate coordination, communication, and more effective response efforts. And then finally, while funding is important, it mainly supports certain functions like surveillance and planning, but on its own, it doesn't necessarily translate into more intensive response activities like investigations or enforcement. The personnel expertise and infrastructure are really key. And taken together, this suggests that effective public health response relies on a combination of people, partnership, and resources, not a single factor alone. So there was a huge influx of money to health departments during the pandemic, but that didn't really, it was sort of like a Band-Aid on years of disinvestment in health departments. Um, so what does this study reveal about US public health and workplace protection? So let's contextualize this a little bit in what I started with, and I'll add some more. So one of the clearest findings from this study is just how central local health departments were to the workplace response during COVID-19. They were not peripheral actors. They were actively engaged in investigations, responding to complaints, and providing guidance to employers across the country. But at the same time, we see really important capacity gaps. Only 40%, remember, reported having personnel with formal occupational health and safety expertise, and only about 42% reported sufficient financial resources. So these are really big limitations. And just over half felt that they had the capacity to fully receive and respond to workplace complaints. So what this suggests is that the system was relying heavily on local public health departments to function as workplace health actors, but without actually building or sustaining that specialized capacity ahead of time. So in other words, responsibility expanded a lot faster than infrastructure. So to understand why that gap really exists, it helps to go back to the structure that I introduced at the beginning of the talk, where in the US, responsibility for workplace health is divided. You have public health with authority over communicable diseases largely, things like surveillance, outbreak investigation, and quarantine. And then OSHA, on the other hand, has the responsibility for enforceable workplace safety standards. Um, and what we see in the data is some of how that division actually played out in practice, at least from the local health department side. We did not talk to OSHA as part of this study. Um, Local health departments were handling complaints, conducting investigations, and advising employers, but often doing so remotely and only sometimes referring cases out to enforcement agencies. So COVID essentially stress tested this split system, and what it revealed were gaps at the boundary between public health and occupational safety. And there isn't always a clear, well-resourced entity able to control infectious disease exposures in workplaces, especially in real time. There, there were a lot of absences in this space. So local health departments stepped into the space, but without always having the tools or the authority to fully act. So again, we don't have data from OSHA about how they engaged with health departments, but that would be useful to understand how these boundaries played out also. We just have the reports from the health departments and only, you know, for the first year and a half or so of the pandemic. Another key finding is that capacity wasn't just an abstract issue. It directly shaped what health departments were able to do. So we saw that local health departments with formal occupational health and safety expertise, more staffing, and stronger relationships with local partners were significantly more likely to engage in the kinds of activities that we would expect to actually reduce exposures, those four kind of groups that I presented before. So the implication here is pretty direct. Worker protection during the pandemic wasn't uniform. It depended heavily on local infrastructure and resources. And that really raises important equity and consistency concerns in the US public health system. Not that there weren't those concerns predating COVID, but this really highlighted that in the workplace realm. Another main finding is around surveillance, specifically our ability to identify high-risk workers in workplaces. So even during a pandemic where there was demonstrable workplace-based spread of infectious disease early on, only about half of local health departments consistently collected occupation or industry data during contact tracing, and only about a third did so at testing sites. It's a big missed opportunity. And this is really striking given how central workplace exposure was to transmission in many settings. And this highlights the lack of a systemic way to identify and track occupational risk in real time in the US with these kind of piecemeal systems. And without that information, it became much harder to target interventions or prioritize high-risk sectors, or even fully understand disparities in exposure by occupation. We are really limited in our ability to do that, even in this like post-mortem period. Um, so this represents a missed and important future opportunity, not just for COVID-19, but for future infectious disease responses. So whenever you find yourself in any space where data is being collected about public health issues, including occupation and industry, is really important. It can shape a lot of decisions down the road. And disease and all sorts of exposures aren't equally distributed across occupation. And then finally, we saw a very high level of demand placed on local health departments by employers. So nearly all health departments, over 95%, reported receiving requests for support from businesses. But the types of support they were most often able to provide were things like general guidance, written materials, and remote consultation. More resource-intensive interventions like in-person assessments or engineering control evaluations were less common. So what we see is a system that is responsive, but is really constrained. It favors like scalable, low-intensity interventions over deeper, resource-intensive ones. And that's not necessarily because those are the most effective interventions, but because they are what the system is structurally able to deliver at scale. So taken together, these findings point to a system that was heavily relied upon, highly engaged, but uneven in its ability to act. And importantly, they highlight some of the tensions between authority, responsibility, and capacity in the US approach to workplace health. And those tensions didn't just stay within public health practice, they also played out in the legal system. And so I'm very briefly, going to discuss some of the COVID-19 era litigation, which is important as we think about future pandemics and local health department authority. So litigation became a key arena for resolving tensions around authority, who can act, under what conditions, and how far that authority extends. And I'll highlight a few examples that connect directly back to the patterns that we saw in the data. And if you're like me, you're like remembering this, like I remember reading the news every day. I wanted to know, how the courts ruled about these things. They felt, and they were, so impactful for public health decision making. So you may remember these cases. Um, so we saw courts placing renewed limits on public health authorities in ways that they had previously affirmed. So in the Roman Catholic Diocese versus Cuomo, the Supreme Court struck down New York's restrictions on religious gatherings. So even with the public health risks of increased transmission, health departments couldn't restrict religious gatherings. And the key issue was that public health measures must still comply with constitutional protections, particularly the First Amendment, which protects freedom to practice religion and right to assembly. And in practice, this meant that local health departments were operating in a more constrained and uncertain legal environment while trying to manage workplace and community transmission. Second, we saw limits on federal workplace authority specifically. So in the National Federation of Independent Business, that's NFIB here on the slide, versus OSHA, the Supreme Court blocked OSHA's vaccine or test emergency standard for businesses. So you might remember that OSHA had issued an emergency temporary standard requiring all private employers with 100 or more employees to ensure their employers were either fully vaccinated or tested weekly and masked while at work. And the court's reasoning was that OSHA regulates occupational hazards, not broad public health risks like COVID-19. They reasoned that COVID-19 is a, quote, universal risk, end quote, shared by everyone in daily life, similar to crime or air pollution, and not uniquely an occupational hazard. We could talk at length about how worrisome that precedent is for other things that we might be worried about in occupational health, but I will keep it focused on COVID-19 for this talk. And this ruling perhaps most directly reflects the structural divide we saw in the study. So local health departments were heavily engaged in workplace mitigation, but the primary federal workplace regulator was limited in how far it could go. And this was a huge limitation. It remains unclear how and if local health departments could institute some of the emergency temporary standard elements within their jurisdiction, and they'd likely be challenged in court. So neither system, public health nor OSHA, fully occupied the space of workplace infectious disease control. And then finally, we also saw fragmenting within states. So in several cases, state governments limited or preempted local public health authority, for example, restricting local mask mandates or business controls. Even where local health departments had capacity or intent to act, their authority was not always stable or consistent. Some states were like really restricted all of a sudden, like Kansas, for example. I didn't get into the state-by-state granularity of experiences in this talk, but I'll note that I also conducted follow-up interviews with health departments in multiple states, and the ways in which state legislators were curtailing influence was of great concern to the health departments, especially for future infection control activities. And if there are questions, I might be able to share more of the details that health department administrators provided in the interviews, helped explain some of their experiences in more depth. Um, so to close, I want to briefly look forward. And I got a question about this in advance. So thank you to whoever submitted that question. But what do these findings suggest for future infectious disease outbreaks? So at a high level, the data point to a few clear needs. First is building occupational health and safety expertise within local health departments, because we saw how strongly that shaped the ability to act. Second, improving surveillance, particularly consistent collection of industry and occupation data so we can identify high-risk workers in real time. And this is my call to all of you in whatever settings you're in. Occupation is really important. It's an important determinant of public health. Third is the strengthening of relationships with employers and with enforcement partners, which were clearly associated with more effective engagement. So those relationships really matter. And finally, sustained funding and infrastructure rather than reactive emergency-driven scaling. Though, of course, we are seeing after the pandemic a real clawback of funds for public health, which is really unfortunate. So that being said, at the same time, it's important to be realistic about what's feasible in the current political and resource environment. And large-scale structural changes may be very difficult, but incremental steps are achievable. So things like cross-training existing staff, standardizing data collection, strengthening existing partnerships, all of those things can meaningfully improve response capacity without requiring major new authorities. And that could even be, forming much more explicit and closer relationships with organizations like AIHA and ASSP in local sections where health departments are based. So some of this is articulated actually in the Public Health 3.0 framework, if you're familiar with that, which aims to shift public health away from traditional agency-centered models and instead towards cross-sector data-driven, equity-focused approaches that address the broader drivers of health with those kind of relationships and reliance on partners. So the main takeaway is that local health departments will remain central to workplace infectious disease response, but whether they can act effectively will really depend on whether we address these persistent gaps before the next crisis. And with that, I will end my talk, and I'm happy to take questions. I don't know if I'm supposed to be looking for questions, Veronica.
No,
Okay.
that's okay. We're gonna give it here. We're gonna give it a minute. If not, I'll read off some questions that we have. But thank you so much for sharing about your research. I think we all feel the same way that you did. Like it feels like it was so long ago, but not. And just I think it brought back all these feelings about
Yes.
living through that time. And
I'm sorry. I'm sorry for the post-traumatic stress.
no, but I think you point out such important key takeaways that I think, especially being in the field of OSH, like we really need to look towards, what are those things that can be implemented. And, so I think it was extremely helpful to hear your findings. So thank you so much for sharing that. So I don't see any questions in the chat yet. I'm going to go ahead and read off some questions, but feel free, like I was saying in the chat, to include it either in the Q&A feature or in the chat as we're going through these. So you did mention that only about 53% collected occupation or industry and contact tracing. Do you by any chance know, have you had like any follow-up to see if any departments have changed that, if there's any different requirements, if there's any different practices. Do you have any evidence of that changing?
Yeah, that's a really great question. The last time I was really systematically talking to health departments about these issues was in 2023. And really, the health departments that whose administrators reported that they had not collected that sort of information and had decided to collect it or realized that they needed to collect it had like a prolonged workplace-based outbreak in their jurisdictions. And so, you know, one takeaway, and this was, in the more qualitative interviews, was that, unless health departments had that experience, they didn't always recognize that they maybe needed to collect that information. And another thing that administrators shared was that a lot of the systems that they have for collecting information at like contact tracing especially, and at testing are already built into like electronic health record systems, and it's really challenging to go in and add extra things or to change things when they've already started collection. So that presented another barrier for many health departments. But we didn't ask about that explicitly in the survey. And so I don't have like really robust generalizable data about that. And it is unclear um, how much discourse this has had since that time. I don't know. I hope so, but I don't know.
Yeah, we hope so. Definitely. But I think it is something, I think that's like a very actionable item and something, that we can share, you can share your findings and make it a point in our local health departments that this is something that, they should be collecting if they're not already. Um, so another question we have on here is, have you looked into other countries that don't have this split system that you talked about to see the difference between like the outcomes and seeing if this is more effective than having a split system? If you can talk a little bit about that, like if in your research you were looking into other systems that were not like the ones here in the US.
Yeah, that is a really good question. And no, I have not in a very systematic way at all looked into, cross-country comparisons. It's really challenging. There are so many different factors at play in across country contexts. And I will say I did read everything that came out from, other countries and that I encountered. Um, and a really significant difference between the US and many of our um, highly developed country counterparts is the structure of our system where, like I started with talking about the Constitution, there are enumerated rights at the federal level, and then everything else falls to the state. That is kind of rare. A lot of the public health um, kind of organization happens at the, federal level in other countries. And so that there are pros and cons to that. And, maybe I kind of was able to get at some of those differences just within the US context in this study by looking at the different governance structures of public health departments, where, you know, the more local levels, if they had that agility to do whatever they needed to do in their jurisdictions, it was effective. They were able to respond really quickly. Um, and that is seemingly some of the struggle that other countries had, with the offset that having really across the board rules was really helpful. So that was a really good question. And no, I haven't done like more one-to-one comparisons systematically, but um, there is evidence that there are pros and cons to both systems.
Yeah, definitely. Thank you so much for sharing that. And yeah, I think that's one of the key differences, definitely. And I think, oh, I mean, this is just more general, but I mean, do you have any recommendations how we, folks in this field can encourage more health departments to have more folks that are in the field of occupational health and safety? It seemed like that was one of the things too, people not having as much experience in the field. I don't know if you've encountered like any I don't know, any advice as to how to like bring that on. Here in LA, we've recently had the Office of Worker Health and Safety be open in our local Department of Public Health, so which is really exciting, but we know that's not common.
Right.
So I don't know if you have any suggestions for how we can advocate for more of that.
Yeah, I would say that my suggestions are really shaped by my own experiences working with health departments, in a variety of capacities. I worked with health departments some prior to this study, which is what led my interest in this study. I had encountered health departments in other ways, like as a graduate student and um, as a postdoc. Um, but I would say that in my experience, there are differences based on like rurality of the health department. So in the rural health departments that I've worked with, and I'll say the caveat is that I'm in Illinois and all of my work has really been in Illinois, like more directly with the health departments. We are a decentralized governance state like California. Um, but the more rural health departments have typically really robust relationships, like with their, um, local commerce organizations and things like that that represent, the business interests. Certainly, the big employers, work with the commerce groups, and those are typically like robust, direct, existing relationships in which I think health and safety folks who work at many of those companies, especially the larger ones that in more rural areas, can can, you know, engage with the Commerce Department, or whatever it may be called in their jurisdiction. And with that can, you know, backwards engage with the health department. In larger jurisdictions, um, like LA, where there is now an office, Cook County, where Chicago is located, where I am, is similar. There has been, in the past decade, a lot of evolution in the like worker health space. Um, and in those sorts of places, there is a lot of opportunity to engage with the health department, typically because they do employ people in this occupational health and safety space and will definitely employ like sanitarians, the folks who are going in and doing like restaurant investigations and things like
Mhm.
that. And so, engaging with the local health department um, is easier in those spaces because those, kind of structures exist. And those tend to be really friendly relationships. I mean, another thing that came out of the interviews that I did was that employers generally like their health departments. They don't like OSHA. They're afraid of the enforcement agencies or they have negative, kind of feelings about an OSHA inspector, but they have much more positive relationships with the health department. And so I think that all of those things are well primed. It does require, I think, the occupational health folks to do some reaching out to these health departments because even in the best cases, the health departments are incredibly resource constrained. And, um, the big companies that hygienists are working for tend to not be super resource constrained. So, working with like a local AHA chapter or something like that, to engage with the health department, I think is a good start. I think I answered your question. I realized I just went on for a long time there.
No, I think that was a great response. Thank you so much for that. And it's good to know, that it is happening in other places too. I think what you spoke of really I think for us hits home with like public health councils, that model where folks,
Yeah,
like you're saying, we're really just wanting to look locally into like what to do. So I think that's where that model came from to really rely on like local agencies. So I think that
totally.
that's a great model to like we could also talk about that at some point to
Yeah.
see how that can also be replicated. But we do have a question in the chat. I'm seeing the pandemic and more recent events pushed a lot of health professionals out of public health spaces. What or where can we attract, engage, or cultivate health professionals to progress health?
Yeah, that's a great question. Thanks, Idris, for posing that. I think there's a lot of opportunities to engage folks in public health and in occupational health specifically. Um, I think one thing that is really important is to ensure that all students of public health, so students who already come to public health with public health interests, have exposure to occupational health in their programs. And, um, I think inevitably, as public health is just so big and incorporates so many different things, some elements tend to be siloed, like occupational health being kind of its own thing. But I think really that's a risky approach because there is so much interplay between all elements of public health, right? All the places we live, the places we work, the places we age. So, in formal public health education, I think it's really important that occupational health has a real foothold. So, if some of you are going into academia, you should really push for general courses to include occupational health, even if it's not specified in the, accreditation standards for public health or something like that. I'll say, more broadly, I think it really behooves us as occupational health professionals to engage in community spaces as much as we can and to work with and make, again, that outreach coming from us as occupational health professionals to organizations who are working with workers on the ground. So, um, worker centers, unions, groups like that, and establishing those relationships because I think sometimes I've had students come to me eventually, adults who were brought in through the labor movement and realized some of the occupational health risks, you know, the traditional occupational health risks, right, that we learn about in like a fundamentals of hygiene course, um, that they were seeing on the job, and they really wanted to learn those skills to address those things in addition to, you know, labor inequities and, structural things about the job. So I think there's a lot to be said about engaging with those spaces and um, showing folks that this discipline exists. It's so small, people don't know about it. I think that's super valuable. So, a lot of work for us all to go out into the community and do all of these things. But I think it's really important, especially, in this moment where there's like a pull away from public health, and certainly funding is really tight and enforcement is really limited. So I think it's a good space for us. Great question.
I definitely agree with all of that. And at our ERCs, we have outreach components, going out into the community, working on different projects. And this is something that if you're all interested in, we want to collaborate with folks in the field. So if you have a way, an idea for us to reach workers, for us to reach employers, for us to reach anyone that you feel needs, to know about this, students, a group of, potential students that could come into this field, like let us know. This is why we're here. So whether it's in our region or the Great Lakes region, um, let us know because we'd love to hear from you. And I think just to wrap it up, and you talked a little bit about how you came into this research and how you had already had contact with health departments as a graduate student. But can you talk a little bit about how you came to occupational health? What interested you to begin with?
Yeah, totally. Always a great question. So my undergraduate degree was in biology, and I minored in physics, and I had actually no idea what I wanted to do. I came to the sciences through process of elimination, like for a degree. And so immediately after I graduated with my undergrad degree, I went through an alternative teaching program, the which was the Chicago Teaching Fellows. It's very similar to like a Teach for America type of program. And I got a job teaching high school science in Chicago. Um, and in a neighborhood that I had never been in, that was so resource constrained and had so many challenges that I had never experienced or witnessed. And as I worked there, I taught high school students. As I interacted with my students and my students' families, it was a largely immigrant community. Um, I really recognized the disparities in public health generally, and occupational health certainly. Um, and I felt very frustrated that I could do so little in that realm in my role. And so I went back to graduate school and I got a public health degree, public health policy. And while I was a graduate student in public health, I took an occupational health course as part of my core set of courses. And I realized I was super interested. Like I was super interested in occupational health and inequities. And I had everything I needed to do industrial hygiene. So I stayed and did a PhD in industrial hygiene. And here I am today, a professor in industrial hygiene. So that's how I got into this work. And I've always been very interested in, all the different organizations and players in the community and how we work together around these fundamental issues of occupational health. So that's how I brought in the kind of health department and all the things.
That's amazing. That's a great way to come to this profession. And we thank you so much for being here and sharing all this knowledge. We'll definitely share your contact info with folks here in case they want to follow up. I have put the evaluation link in the chat, but just as a reminder, I will send a follow-up email with the evaluation, with the slides, and any other resources that we want to share from this presentation. So with that, thank you so much again, Dr. Bonney. Thank you so much for being here, everybody. And hopefully we'll see you all at the next guest speaker series in April. But yeah, have a great afternoon, everybody. Take care.
Thank you so much for having me.
Thank you.